Good morning. Good morning, everybody. My name is Stephanie East, and as most of you know, I'm the CANS trainer for PSU.
And I'm Angela Wheat with Oregon Health Authority.
Welcome to our monthly CANS webinar. We appreciate the continued support that we've had from a lot of you, especially with moving this towards more of a technical assistance thing and being able to offer you monthly support in terms of CANS. So to get it started today, I'm going to turn it over to Angela to give some updates from OHA.
Melissa, do you want to give any instructions?
This is Melissa Mybore. I help with technical support, and I just kind of wanted to give you guys some instructions. So what I'm going to be doing in the next couple minutes is unmuting everybody. This means that you have the capability of muting yourself. So please be aware of background noise. If there is background noise in your room, I will most likely mute you on my side, so there is no disturbance during the conversation. But if you do have questions, since you will be most likely unmuted, please feel free to ask questions. There's also the chat option, and I will be monitoring questions throughout the conversation, so feel free to type in questions as needed. And if the presenters are talking during the and you have a question, feel free to use the hand raise option, and I will ask the presenters to pause, and you can ask your questions. So without further ado, Angela.
Thank you, Melissa. So in terms of updates from the Oregon Health Authority, I think, as you know, we've discussed on these calls and I've been around the state talking about, is that the CANS use within wraparound started on January 1st, 2016, and many CCOs have already implemented that and have gotten their training from Stephanie, and then some have yet to do that, and that's fine. We're doing a soft implementation, and there are no reporting requirements attached to that at this time, so we would just encourage that you get a hold of Stephanie to get some training on that. And then there's a lot of other changes in the Children's Mental Health Contract for 2016 that will impact how community mental health providers are serving youth and families. So Oregon Health, our child and behavioral health team, we're working on some guidance documents that will just help clarify those changes and reduce some of the confusion that we know is out there. So we'll get some frequently asked questions out, as well as a spreadsheet that makes things a little more clear and pulls it all together. So we're working on that and hope to get that out really soon. I'd love to have that out in the next 1 or 2 weeks. That's all I have in terms of updates.
Does anybody have any terms or any questions for Angela in terms of OHA or any updates that you need from the state that we haven't covered? All right, well, if anything comes up and you have any questions, please feel free to type in the chat box or ask us. The reason that we're really trying to do these calls is people to support CANS, but understanding where things are at with the CANS in terms of state implementation and what's been going on with training and PSU and all of that stuff. So moving ahead, a little bit of training updates. So these are the regions that are scheduled so far. In terms of CANS 101, there's only one upcoming training right now. In the recent future, I believe Yamhill has one scheduled as well, but that's a lot further out. But the only one that's upcoming is the my response to that is yes, absolutely. What we're trying to do with the 102 is that's really looking at CANS infusion into wraparound. So it's really important that everybody from the wraparound teams, your family partner, your youth partner, your care coordinator, all of that are involved in those trainings. They understand the changes that are taking place. Our 4-day trainings are in the process of being updated as well to reflect cans infusion into wraparound. So it's something that we're really trying to push forward in terms of having it be a meaningful tool that informs your care planning and informs everything that you do. So those are the upcoming training dates scheduled. If you want to get something scheduled, please contact me. I know Eastern Oregon is also, I've been talking to them about doing something out there in the near future, so I will follow up with that as well. But looking forward to training everybody, and as always, if you have any feedback or suggestions, please feel free to let us know. In terms of the CANS 101 trainings, I think they've been going very well. One of the things that we've really found is there's a lot of discrepancy in the way that people are rating. It's really been difficult to kind of narrow that and to support people with understanding the tool and how to rate it appropriately. And so I think that's been one of the biggest struggles in terms of doing this training is people are rating so differently. But I think the CANS 101 has been helping to kind of narrow that lens and support people with rating a little bit more correctly. I don't know if there's anybody out there that has been to any CANS 101 trainings yet, but if anybody has any, welcome that. These trainings have been going pretty well so far. I think we've got a much better kind of feel to them, but I'm always open for feedback. Overall, I think they've been going really well. The Youth Move 1 and OFSN in particular was the most recent one, and that one went really, really well. It was great to see so much excitement around the CANS and the different uses that can be applied to it. So really with the goal of CANS 101 again, it's just to really give participants a chance to practice rating together and encourage that consistency of rating. And even among people that are really familiar with the tool and have been using it a long time, we're still seeing a lot of kind of variation in the way that people are rating items. So hopefully this will help us all rate a little bit more consistently and more accurately. And we're going to keep moving forward with fine-tuning these trainings as well. One of the things that I wanted to bring up as well, along with the CANS 101, is there have been a few people who are really, really struggling to pass. So I want you to understand that even if you've done this training, if you still need additional support, whatever is needed to kind of help support that. And maybe between Angela and myself, we could figure out where the biggest struggles are coming from and provide more support around that.
Another consideration, if you're setting up a CANS 101 in your area, in your community, one thing we're noticing is that when we have a blended audience, for example, care coordinators for wraparounds, and then also raters who are doing CANS for child welfare, that tends to kind of muddy the waters a little bit because those are pretty different lenses, and while we're trying to bring all that together, we're finding that that can be just a more muddied training audience and more difficult for Stephanie to maneuver all those nuances. So I would suggest we want to get everyone trained, and it's fabulous that the child welfare raters have been coming to these trainings. I think we might just want to separate those a little bit, or to just be really clear about the intention of each training and who the desired audience is. So if you have any questions about that, please let us know.
Along with that as well, with the CANS 101, one of the things that we've also done is we've basically set up two trainings. There's regions where they have essentially no exposure to the CANS, and so for that we're doing the full day training. But for regions where care coordinators are pretty consistently using the CANS, one of the things that we've done is done like a half day, just like these are the principles, these are the little nuances around it. Do we have a question?
Maxine Day?
Yeah, the child welfare raters, I'm not sure I understand who those are.
How do you use the CANS?
We're referred from DHS to do the CANS.
Yeah, so that's what I mean. So
we're a child welfare rater.
you do not work for child welfare welfare, but I just mean that you're responding to referrals from child welfare for a CANS and entering those into ORCID.
So am I a child welfare rater then?
Yeah, sounds like the same. I think we're saying the same thing, yes.
What region are you in?
Eastern.
Okay.
Do you do wraparound care coordination?
No, Colleen does that.
Okay, yeah. So she would be looking at CAMS through the wraparound lens, and you have a little bit different take on it, although we definitely want to make sure that we're not doing duplication. But if you're providing CAMS in response to a child welfare referral, then yeah, child welfare.
Okay, is child welfare, should we expect them to give us full information or a one-sheet page information?
That's a good question. I can't speak for DHS. Tom, do you want to speak? I think you're still on the line. Do you want to speak for what those referrals should include?
Hi, this is Tom. Hope you can hear me. What we're looking at is for the referrals from child welfare. They should be the same referrals that they're doing for mental health. So whatever information the branch or the worker generally gives for a mental health assessment, they should be given the same information and referral information for a CANS.
Okay, because we had a referral and it wasn't in depth enough for us to really do a CANS. But the worker said that her supervisor did not want to give all that information to us.
Well, and that sounds like something you'll need to work with, maybe with the branch on getting more information to do that. And I
was just wondering if there had been a change or something.
There's been no change. No, not from central office.
Okay.
And if you get what you get, you can only rate how you can rate, right? I mean, if they only give you limited information, then you can only rate it based on what you receive.
Okay. Thank you.
Sure.
Jenny Barrett, do you have a question? Let me unmute you. That would help. Jenny?
I didn't have a question. I accidentally hit the button and I didn't have one, so sorry.
Okay. All right. Maxine, do you have another question?
No, I thought I had to lower my hand, that's all.
Okay.
Yeah, so in terms of the training audience, I think where it's really been muddy is we have people in the audience at times who have never seen it, and then we have people who are rating it for DHS. And so we've gotten some pretty strong feelings from some of the raters that have been in the room. So it sometimes, I think, can make it a little bit intimidating for those who are newer to CANS. So we're just trying to kind of make sure that we're really clear that we know kind of the barriers that are in place, and we understand that the CANS 101 training is really specific to understanding the tool. And again, the way that we've been doing them now is for those regions that are really familiar with the CANS and have been using it consistently, we're doing like a half-day kind of modified training for those folks. But for the ones who haven't and who really need the practice and who want to have a better understanding, we're doing the full training. So again, it's totally customizable to whatever the needs are for different people in their region. Again, just a reminder, with all the trainings that we've been doing, it would be great if we could have people from those trainings who are on the calls, specifically care coordinators, anybody who has any of those questions around the CANS, around using it, around rating specific domains. Now that we have Tom on the line, any questions around DHS, scheduling, et cetera, this is really what we want those calls to be about. I would really like to start getting more topic ideas and suggestions from you guys. I mean, these calls are here to support you with your needs. So just something to keep in mind. And again, coaching is available. We're here at any point to support you with this rollout as it continues to progress.
Maxine, do you have another question?
Yeah, just for understanding, so if we wanted to, mental health wanted to do to wrap around, we would do it differently?
Are you speaking to doing the cans? Like,
Yeah.
actually rating it?
Yeah.
The ratings never change. I mean, the CANS tool is the tool. You rate it the same way, whether you're doing it for DHS, mental health, or wraparound. That doesn't matter. However, what's different is the way that you use it. When you're using the CANS and wraparound, it really infuses into a lot of things that you're doing. Your CANS items should be incorporated in your safety plan. They should be incorporated in your crisis plan. They should be in your plan of cares or your service plans, whatever it is that you do. And so that's what we're really teaching to in those 2-day trainings is we're trying to expand on the 4-day training and say, okay, we've given you all this training and knowledge about wraparound. Now let's take it up a notch and understand how to use the CANS and all these specific tools to help make the practice a little bit easier. So that's really the difference. It's just the way that the scores are used.
So as a mental health therapist, I really need to be aware of how to do it for a wraparound too.
Are you sitting on the child and family teams for wraparound? Tell me how you are involved with wraparound.
Well, if I have a child and I have to refer it to wraparound, don't I have to do wraparound stuff?
You'd be on the child and family team, but the wraparound care coordinator is ultimately responsible for ensuring that the CANS is completed.
Okay. So if I have a child, I just fill out the papers, do pass on the CANS that I've done, and then it's up to them to do everything else.
So
I'm trying to understand.
Are you doing CANS for youth and child welfare?
Yes.
Okay. So you would do those all the same, and you get those inputted in ORCIDs the way you've been doing them. And then in what community are you in again, Maxine?
I'm in Grant.
Grant, okay. So in every community is different how this works, but ideally where we like to get is that then the wraparound team could use the initial CAMs that you did and not have to duplicate that work. As question room.
Right.
But something that I'm kind of in a similar boat. Sorry, my name is Kristen, and I am a mental health therapist that's contracted to do the CANs for DHS. But occasionally I'll have to refer a kiddo for a higher level of care, which is, I think, what you're kind of asking at this point, but you would probably do ongoing care. But I've actually sent the CANs over to the wraparound team, too. So I guess at that point they could use the material that we did and maybe update anything that they need to update on their end. But I sent, like, the mental health assessment, the CANs, and then all the referral paperwork for the ISA, just all in one packet. And then they can work from there probably.
And for the care coordinators, too, the other thing to kind of know is when CANS is used correctly in wraparound, it's going to be done much more frequently than it's done in DHS. So what we're recommending is at intake, discharge, quarterly, and life-changing events. Because for our youth in wraparound, it's good to track their progress more consistently and to really see where are they at, how are we improving, are we meeting those safety goals, are we dropping in different domains. And for the wraparound supervisors, it gives them information about outcomes and how things are working and stuff like that. So that's really one of the differences, too, is that the care coordinators in wraparound are really going to be doing them much more frequently.
I'm on the CANS technical call. Maxine, do you have another question? Does that answer your question?
Yes, thank you.
You're welcome.
So one of the things that we've been asked to do, and we're going to put you on the spot a little bit, Tom, but one of the things that we've been asked to do is to get DHS to be involved in the call so that we have kind of a way to get some of these questions answered that people have. So I'm going to kind of turn it over to Tom, if that's all right, to kind of update what's going on with CANS from the DHS front. And for those of you who have questions, please feel free. This is the time. You know, you have some
So as Angela, I think, said earlier, if a CANS is done for us, for child welfare, when a child first enters foster care, that CANS should be given to any team that's working with the child. So if the child enters a wraparound, we're trying to tell our workers, give that CANS information to that WRAP team so they have that information, and they can use that to build on and go forward with the information that's already there, rather than having to reassess and start from scratch all over again. So we're trying to get that practice integrated into our system, and honestly, it's a struggle because in some ways our workers have viewed the CANS as a rate-setting tool, and we've been working for about 5 years to debunk that kind of thinking. But once something gets embedded, it's really hard to undo. So we've been out training our new workers and old workers on the idea that the CANS is really meant to be an integration tool and is meant to identify needs and strengths in the use of case planning and development plans. So we're making some progress in that and some headway in that. So you can hopefully hear more about that. And what I would say for you all as mental health providers is, once you are working with a child, ask the child welfare person for the CANS if you don't have it. They should be giving it to you. They should be passing it on to you. So we want to make sure that that is happening. The other thing I guess I would add is that when we do our rescreens, what we call rescreens for CANS and annuals for CANS, what we are asking the branches to do is find out who is working with the child and to have that person update the CANS information and not go back and give it to somebody who doesn't know the child. So we have someone who's working with the child who can simply update the information and not have to do a reassessment all over again. So those are some practice areas that we're trying to integrate within our practice. And I'm open to questions that any of you might have.
I have a question. Tom?
Okay.
Hi, my name is Kristen Summelsberger. I am contracted through Morrison to do the CAN screenings for the Gresham DHS branch.
Mm-hmm.
I'm just wondering, I know that there's been talk about adding or modifying the CANs for the wraparound team to include some of the caregiver questions that I think have made it a bit more maybe accurate or reliable or inclusive of all the needs that are going on with the family that is helping the child. Is that something that DHS is going to consider at all? I've had a lot of feedback from families, foster families, saying that it's really, there's just a real negative view about the CANs and actually what it ends up producing. I think the foster families feel relatively unsupported by it, the process and what it produces.
Okay, yeah, I think I follow you, Kristen. And I understand the part about foster parents, and some of that has to do, again, back with the idea of how we're utilizing the CANs and trying to get workers to understand how to use it in work. And I think that is some of the key to that, so we're working on that. In answer to your questions about changing the items in the CANs, we're working together with OHA and PSU to develop an updated CANs. And part of it, some of that is going to have the trauma piece in there. That was really lacking. There's a trauma CANs out there, so we're going to really move into that direction. And we've updated some items in there. And there is a caregiver section that's a part of that. But we'll need to do some training on that, because in part of the thinking about who we define as the caregiver for that, in my understanding and talking to Dr. Lyons and the thinking is foster parents aren't really the people who would be rated in that caregiver section. And that will be something we'll talk about when we get in there, because it's really the idea would be who is going to be the permanent resource for the child, and talk about those caregiver strengths rather than a temporary placement kind of piece. So we'll have to do a lot more work on that and building that and getting that together.
On line two, going along with that, Tom, on line for the caregiver strengths and needs, typically what PRAE does is it has to be more with like term, with the amount of time the child is with the caregiver and who the child defines as their caregiver. So if they've been, in a long-term foster placement or they're free adoptions or those types of things, those are situations where you would rate the foster parent. But I agree, those are further conversations that do need to happen to make sure that everybody's rating the same way. And as that rolls out, we'll be able to offer additional training through PSU to support everybody with learning the new model and understanding what's kind of going on with the newer version.
Right. Yeah. That's a good the addition, Stephanie. I agree. It really there's factors we have to look at. Absolutely.
Are there any more questions for Tom?
This is your opportunity. I heard you all out there had a lot of questions. Patty.
Yeah, we had a lot of questions for you the last time.
Yeah,
for sure. And some of the trainings we've had quite a few questions as well. So we're trying to route those. But hopefully, if you can return for our call-in next month as well, we can start to get the word out that you're going to be available to answer those questions.
Yeah.
Yeah. Either Joe or myself will make a point of being available for these calls.
Great, thank you. I really appreciate your support, and it's been great to see all the collaborations going on, not only between DHS, OHA, and PSU, but also with OFSN and Youth Move and all the other people that have been pulling together to embrace the CANs, get trained. Health Share and Family Care did a training recently, who are starting to kind of buy into it a little bit. So that's been huge. I mean, we can't do this implementation without support from everybody, and so seeing it start to progress and seeing a more positive response and it move forward has been great. So,
Deborah Hawkins has a question. She just wrote me. I'm not sure if this is the person, but could you talk about SCIP and SAIP and if CANS is required as a level of care measure?
So Skip and SAFE are hospital level of care for children and youth. But this time, CANS will not be used within the mental health system as any type of level of care tool, not in 2016. It's possible in 2017 when we have the eCANS system and a new way of doing analysis and reporting within that system that we may choose to build in an algorithm that would allow us to look at recommendations for level of care. But we're definitely not, we don't want the, sorry, the phone said something. We don't want a tool to dictate decisions like that, over-dictate decisions like that. So we're going to really need to think about that with the Praise Foundation and get some recommendations from Dr. Lyons as we move forward. You may be asking that because we're no longer requiring the CASI and the EXI. Some CCOs may choose to still use those tools. And as you know, Nancy Allen in my unit at Oregon Health Authority is the one where all the Skip and SAFE referrals come to. And she won't be looking for, there's no way that the CANs right now can produce a score that would help inform whether or not that level of care is needed. You need an algorithm for that. So the answer is no. That was my long-winded answer.
She has another question. This is from Terry Dickens, actually, and she has a question: what will be used as a LOC tool?
Level of care tool. So,
is the BERS still required?
CPRS and BERS reporting still required. However, if you don't enter the CASI and EXI score within CPRS, now you can still enroll or save that screen. So CASI and EXI are no longer required, and there's no new level of care tool being implemented at this time. We really want our system to move towards a needs-based conversation related to what services or supports are needed or are going to meet the needs of children and youth. So Child and Family team should be just having those discussions and bringing in the psychiatric recommendation and all the pieces that would help us determine the level of care the child needs.
Amber has a question. Terry says thank you. And Amber, I'm going to unmute you right now. What is your question?
Yeah, this is Amber Clegg with Deschutes County Behavioral Health, and it's sort of a technical question for ORCID, so I'm not sure if this is the right forum for this or not, or if I should contact Tom separately.
Go ahead.
Tom's still on the line.
Okay, so we're running into problems where we have a lot of providers who are certified to do the cans, but so that means some of them don't get in very often. So what we're running into is a lot of them have their accounts deactivated on Orchids because they haven't logged in, I think, within 90 days. And it's creating a huge hassle, lots of time spent trying to get their accounts reactivated, and we're not always getting the right links when they say they're being reactivated. So I'm not sure, is there a way to get reminders over email, your account's about to be deactivated, or an easier process for that? It's been a pretty significant issue for us.
Yeah, I understand that, Amber, and it has been an issue with other folks too, and it's just a thing with Orchids that it automatically cuts you off, and there is, as far as I know, no automated message that is sent out of a caution for that. I can ask and see if there's possibility for that. But what I would say is, if you folks run into that, call me and call Joe. We can probably get your folks back into it quicker than if you call our help desk. Our help desk is going to put you on hold probably. So we can probably help faster. But I'll check into that. Any kind of message.
Okay, thanks for at least checking on that. I mean, it would save, I think, your guys' tech folks' time and your and Joseph's time too. Sometimes it's been hours on the phone and over email trying to get that reactivated.
Right, that's what I'm saying. Don't call them, call us.
Yeah. Okay, thank you.
Yep.
Okay, anything else?
Well, if nobody has any other questions, there's no other updates from our end. Just kind of a reminder, feel free to contact us at any point. We're here to support you and help you as this continues to progress. And again, submit your questions, anything that you want to know, and take advantage of this. This is the time you can grill us, versus the trainings. So this is the time that we can really be available to answer those questions and to have those difficult conversations when we're not trying to have a conversation about how to rate the tool correctly. So thank you again, everybody, for attending. Oh, we have one more question.
Jenny, you have a question?
I do. It's about one of the domains. I discussed this with the other wraparound care coordinator here in Baker, but I'm going to ask you here, and if there's a conversation that needs to be had elsewhere, maybe one of you guys can contact me or I can contact you. I recently did cans on a youth here that just started RAP, and when we were talking about eating disturbances, his mother discussed that he may be diagnosed with Prader-Willi, which is a little bit more different than what that area talks about regarding, with the eating disturbances. So I rated him as a 3 because he's not been actually diagnosed with that. But I'm feeling a little uncomfortable with it because in the cans it talks more about, binging and those kind of eating disturbances. It doesn't talk about a youth that may have, eating actual objects or eating dirt or eating things like that. So I just feel really uncomfortable right there in that area.
Are you speaking to the 0 to 5 or the 6 to 20? How old was the youth that you were?
6 to 20.
Okay. So I'm pulling that up right now so I can look at it while I'm giving you the answer to this question. But do you have anything you want to?
It doesn't have it in the description. She's right. It only talks about anorexia and bulimia. But I always rate it as if it's like pica or something like that. I usually rate in the safety section and the eating disturbances section, and I don't know if that's correct or not. But
basically, for an item like that, and correct me if I'm wrong, anybody who's listening, but for an item like that, it's really, is it going to translate to action? Is that something that you're concerned about? Whether or non-specific is okay, it doesn't matter. It's really, what are you going to plan around this? It sounds like for that youth, that was a very specific thing, so you're absolutely right to rate it because it's something that you're going to include in planning. And it is a safety risk, absolutely, so that's something that you would rate in safety as well. So it's important for those types of things to note that it doesn't necessarily have to fit word for word into the description because our youth are going to present with all kinds of different things. But it's something that if you're going to have a plan around it, it needs to be rated in your CANs, basically.
Okay, wonderful. So then I feel like I did what was appropriate as well as my other wraparound care coordinator after we discussed it where it needed to be. So thank you so much.
Yeah, exactly. If you had rated it no evidence of need, that wouldn't have been appropriate, right? Because there is a need there, so that's absolutely fine to rate it that way.
Okay, thank you.
Do you have anything on that?
No, I actually agree with what Stephanie said. We should think in the broader sense of the use of it and figure out is there going to be some action behind the item or not, and if there is, we need to rate it somewhere, and that's probably the most appropriate place to rate it.
Absolutely, and I believe in the 0 to 5 for younger ones, it's a lot more specific in terms of that kind of stuff because that's more what they're looking for. And I think we're exploring a developmental version of the KENS as well, right, for the future at some point.
I don't know, are we?
Hopefully. So that one.
Yeah, our new 0 to 5 version has a different category for eating disorders than what's in there currently.
Yeah. All right. Does anybody have any last questions? Otherwise, we're going to go ahead and sign off for the morning. But again, we appreciate everybody's attendance. Oh, we have one more.
Terry has a question. When will the guidance documents be available regarding the new children's contract?
I'm trying to get them finalized. I'm collecting. If you have any feedback in terms, email me your questions. I'll make sure that those get on the frequently asked questions document that I'm creating. And then I'm working with my team on just making sure I know all the questions and confusion, everything that needs to be on that. And so my goal is the next 1 to 2 weeks. And if you don't see it, then contact me in 2 weeks and I'll send it to you directly. I'll get those out to the CMHPs and providers and CCOs, but I could miss someone, so just reach out. We also have a frequently asked questions document for the CANS. I believe most of you have seen it. That was also pulled together collaboratively with input from Tom and from Angela and myself. And so if you haven't seen it, if that's something that you want, we have copies of it available that we can email to you. And if there's things that you want to contribute to the document, questions that you want answered, it's a live document. I update it almost every month to reflect changes that are going on in the communities. So let me know if that's something that you want as well. And as we continue to move forward, I'm sure the document's going to continue to change and grow. And I do believe most of you have seen it, except for maybe the people in Southern Oregon, Eastern Oregon, because those are the 2 regions that I haven't really had much opportunity to work with yet. Anything else?
Well, thank you everybody for your participation. Thank you Tom and Angela for being available to support with us. And I enjoy doing this every month, and we will see you guys next month.
Thank you.